take that as a yes. So thanks everybody for joining. This is our quarterly MHRC seminar, and we also consider it networking, and we're returning to it kind of an older format today to listen to the ideas of a former consultee of MHRC services, Abby Cheng, who is preparing an R01 for submission in a little over a month, and so wants to get some feedback on aims, and so she'll spend a few minutes presenting that, and then we'll try to keep the rest of the time for questions. But I want to give you some updates first. So as you all probably know, our fearless leader, Eric Lenz, is now the lead of our department. He's our department chair for psychiatry. So we're transitioning to a little bit of different leadership. So I'll be taking over that role, although it'll be hard shoes to fill. Katie and Stephanie will stay in their roles. And then we have two new team members to introduce. So a lot of you probably know Ellen Fitzsimmons-Kraft. She's going to take on a leadership role with me and helping me to co-lead efforts into the next phase of MHRC development. She is an assistant professor in the Department of Psychiatry and really does fantastic work in mobile health, extensively published, relationships with lots of cool industry partners, and just a wealth of knowledge. So we're really excited to have her as the leadership team. And then Teddy Gray, formerly of John Constantino's lab in the Division of Child and Adolescent Psychiatry, who is helping us to build the MHRC core. We now are officially an ICTS core, and Teddy has a lot of street cred developing cores like the IDDRC, and so we're really excited to have her expertise in kind of standing up more services and being able to help more people. So let's see. So just to give you guys a reminder, this is the stuff that we said that we were going to do, that we've so far been able to accomplish under Dr. Lenz's leadership. But sort of the catchphrase we'd like to move towards is digital health solutions, because what so many of those of you who have consulted with us or worked with us over the last few years have learned that mobile health is really important, but digital health sort of encompasses more of all of the different ways that you can incorporate technology into research. And so we want to encourage that broader perspective, but sort of always connecting back to the roots, which are mobile health. But we primarily have been doing consultation, which is tailored guidance, one-on-one, emerging researcher needs, but sort of like from idea to implementation, engaging different folks from different places where there might be resources, and connecting people by networking. Events like these, which, you know, over the last couple of years has been a little bit challenging, but we've still been able to manage to have these events, and they seem to be very well attended. So thanks everybody for attending today. And our navigation tools, which if you visit our website, you'll be able to see that growing list of just, you know, helpful, simple, but easy to follow resources that help you navigate the different institutional things that need to be connected if you're going to successfully launch a mobile or digital health project. But there are a couple of things that we want to be able to do as we move into the future. These are things that we sort of thought about under Dr. Lenz's leadership, and that those of you who've been giving us feedback along the way have also told us about, but really using new communication channels to push out information, but also to receive information back from you. So being able to promote your ideas and successes, so sort of a way of meeting innovation and disseminating it into the community by having folks come and give talks, more like a Q&A sort of thing. So we learn about their work, but we also learn about them. A Meet the Innovator podcast that would sort of go along with that quarterly seminar series that we've been doing for the last few years, and then a newsletter as well. But there are other ways that we can get information out. And so those of you who are, you know, in the world of technology, we want to hear from you. What are other ways that you would like to be contacted or, you know, receive information, or which channels do you think would be most effective for pushing out at least the information about what you all are doing? And then also connecting you with innovators outside of the institution. So workshops for skills development that are run by folks outside of the institution that have skills or resources in areas where we don't. One of the cool things that Ellen is doing is virtual reality. And so, that could be an example of a new tool that we have folks come and talk with us about and develop a skill set around incorporating into research studies. Just one example. But also expanding our networking and seminar series so that it reaches folks that are part of our expanded CTSA network. So partner institutions for our ICTS, but then also other institutions that have CTSAs like ours, and what are they doing around digital health and mobile health. So some ideas to come, but if you have thoughts about these things, please feel free to let us know. And finally, kind of figuring out the needs assessment of the different range of investigators that we've helped over the years. We sort of learned from people in training what ideas they have and how those ideas can then grow into a K award, for example. We just had our first K award funded this summer. So super exciting. Mary Catherine Ray is the first K award to be funded through the MHRC's assistance. Of course, we didn't do everything, but we're proud to be able to say we helped her. And so, those are the things that we really like to highlight, but we also need to know what are the things that you need to help you move to that next phase of your work. And so you see this sort of hierarchy of digital needs. This is kind of where we want to think about things. So, love and belongingness, I guess this would be one of those things where we're helping to network. But we're going to be sending a digital survey, hopefully in the coming weeks. And one of the things that we want to know from you is, what are the biggest challenges that you face in your digital or mobile health research, or just your research in general? Where could digital or mobile health tools be most helpful? Or do you even know? Is that still an open question? When you have problems or challenges, where do you go? Who do you seek out? Because those are resources then that we might need to know about so that we can figure out how to formalize a resource like that or create more capacity in a resource like that. Which tools will best position you, your team, and also us as an institution as leaders in this space. So we have a lot more growth that we can achieve. But I think, with the fine minds that are on this call and those of you who have helped us grow thus far, I think this is really where we want you to be our partners and thinking about how do we move to the next phase of becoming leaders in this space. And so now, without further ado, I'm going to let Abby Cheng take over and talk about her idea, which is pretty well formulated at this point. She's got an entire grant written and has gotten our feedback on it already, but would like to get the experts on this call involved. So she's going to give us a quick presentation on the background of her grant application. And then she's got some specific questions that will help her kind of facilitate getting feedback from the audience about. I will let you take over screen sharing.
Okay, can you see? It's working. Okay, wonderful. Thank you so much to Dr. Nickel and the mHealth Research Corps for, I would say, many things. I have come to you for my pilot work and then also for this R01. And like Dr. Nickel said, I would love feedback today. So that's really my goal. I'm going to try to go through the background fairly efficiently. So if you have questions at the end, feel free to ask more. The title of the R01 grant is Mental Health Intervention During Orthopedic Care for Chronic Back Pain. And this will be a sequential multiple assignment randomized trial, or a SMART, which I'll describe more about that in a bit. To give more background, this is going to be submitted to the NIMH. October 14th is the deadline. So that's my timeline for making revisions based on your feedback. So to give some background on the problem, I am an orthopedic specialist. I see a lot of chronic back pain, and we know that in itself is a huge burden. Sorry, also my light turns off in my office. So that's going to happen a lot today. The burden from chronic back pain from a personal and societal level is massive, but it's also a bidirectional risk factor for depression and anxiety. From the orthopedic standpoint, we cannot treat back pain well if there's coexisting depression and anxiety. And on the flip side, in the mental health domain, if you have chronic back pain or chronic pain of any sort, it is harder to treat depression and anxiety, and standalone mental health treatment is not as effective. So the novel piece to this grant is that we're proposing to co-locate mental health care in the orthopedic setting. There is more motivation and awareness in the orthopedic world that our outcomes are driven in part by mental health, and now payers are starting to reimburse based on outcomes. So there is this this momentum, but we don't know how to treat mental health and address it effectively in this orthopedic setting. So that's where all of the premise of this entire proposal is coming into play. In terms of interventions and solutions, we shifted towards a digital mental health intervention for a multitude of reasons. Number one, they are digital interventions, regardless of what it's for, can improve access, can improve affordability compared to in-person care, and it can be more approachable to talk about in an orthopedic setting, rather than saying, I think you need to go see a counselor, say, hey, why don't you try this app? Apps are very common. There's more confidentiality and anonymity for patients who want that sort of thing. And so we've done a pilot using an app called WISA for chronic pain. WISA is a million user app company that has a general mental health app. But they've also developed this app called WISA for chronic pain specifically. It uses a behavioral activation framework and works toward pain acceptance. So it helps users try to find joy in their days despite their pain, and not let pain essentially ruin their day or dictate how their pain goes, their pain or their day. In our pilot, we compared high WISA users to low WISA users. So full caveat, this was not randomized. We did not have a true control group. But among the high users, those patients improved their depression scores, their anxiety scores, and their pain interference scores to a clinically meaningful degree compared to the low WISA users. The anxiety score difference met statistical significance. Again, this was a pilot, but the depression and pain interference scores showed promising results as well. We did another pilot study funded through the Center for Perioperative Mental Health. So thank you again, Dr. Lentz. And we looked more from a qualitative standpoint regarding implementation of any sort of mental health intervention into the orthopedic setting. And we've gotten a lot of data. We're still writing it up, and I'm trying to get that out and published before this R01 gets reviewed. But the general gist of things is a lot of patients really like digital. There are also a lot of patients who are not digital tech savvy folks necessarily, or maybe they are tech savvy, but they say, when it comes to my mental health, I'd rather talk to a person, or I'd rather find local resources. I just don't know where to look. Or patients who say, I just need a piece of paper, and that's how I function. I don't look on an app for this sort of thing. So we really want to be mindful of all of our patients, and we realize that we're going to need to approach mental health in a multi-component sort of approach when we're actually addressing things in the orthopedic setting. So that piece of the pilot data has played a role into the study design. Like I mentioned, we're going to be doing a SMART, or that's what we're proposing, which essentially means that patients can be randomized more than once through a longitudinal setting in the grant or in the study. This will be a type 1 hybrid study, meaning that we are really focusing on effectiveness, and in this case, the effectiveness of the digital intervention, WISA for chronic pain, but we're also looking at implementation outcomes with the idea that we want to implement this and be successful with that in the future. Again, we're focusing on the digital intervention, but we will be looking at a printed intervention as well. And the patient population is really patients coming into an orthopedic clinical setting, so not pain management, not any sort of chronic pain setting necessarily, but they're coming in to see a spine surgeon or a non-surgical spine specialist. And they have chronic back pain, but they have coexisting symptoms of depression and or anxiety. Our primary outcome measure is the PHQ ADS measure, which is essentially a composite depression and anxiety score using PHQ-9 and GAD-7. And our central hypothesis is that incorporating this digital intervention into usual orthopedic care will improve the things we saw in our pilot work: depression, anxiety, and pain interference. Like I mentioned, the secondary outcomes and secondary things we want to look at are that printed resource and then contextual determinants of implementation success. So this is the wording, oh, there's my light, of our aims. And I will take feedback on the wording as well as the concept of these. Aim 1 really is to determine the effectiveness of the app plus usual care compared to usual care alone for the population I mentioned. Aim 2, we specifically are calling it an exploratory aim to explore the effectiveness of the printed guide of mental health resources, specifically in patients who don't respond initially to usual orthopedic care with or without that digital intervention. So again, we have the most data for effectiveness with the digital intervention, but not everybody is going to respond to that. We predict that based on our pilot work. So will a printed resource potentially supplement mental health symptoms for those patients? And then aim 3 is to identify the contextual determinants of implementation, specifically that impact patient reach, engagement, and effectiveness with mental health intervention in the orthopedic care setting. And like I mentioned, I have until mid-October to continue to revise this. The R01 mechanism is specifically an effectiveness kind of incorporated with implementation type of approach. That's what they're looking for. So we really do want to meet that pragmatic trial approach. The innovation that we discussed in the grant include just shifting that orthopedic clinical practice paradigm from a very structural based orthopedic approach to really thinking about the whole person to improve orthopedic outcomes. And hey, if we can also improve mental health and kind of whole person function, that would be great too. We are being responsive to the funding mechanism by looking at the digital intervention, by using an adaptive trial design with the SMART and really focusing on a pragmatic hybrid type of study. And then again, what's unique to our study is that we are looking at the orthopedic care setting, and we're trying to work toward this personalized medicine approach where, you know, if you're not responding to what we give you, can we try something else and see if that makes a difference for you? In terms of the frameworks that we'll be using for the entire kind of premise of the study, we're talking about the biopsychosocial model of pain. That essentially means that pain is not simply a response to a structural stimulus. It's not just biological with musculoskeletal structure. The experience of pain also depends on the psychosocial aspect of how a person is functioning and what else is going on. So depression, anxiety, do you have access to mental health support? And if not, that's going to play a role into all of your other symptoms, both physical and mental health related. And then from an implementation standpoint, we're using REAIM and the PRISM framework to guide our study. So like I mentioned, we're focusing on orthopedic patients. Our goal is to recruit 300, which over the course of this, it'll be a 5-year grant proposal that we're asking for. And from our pilot work, we do think that's appropriate and feasible. To mirror the demographic representation among patients with chronic back pain. We're targeting for 55 to 75% female patients, at least 25% or more who identify as a racial or ethnic minority. We exceeded this in our pilot work. And then in terms of approaching patients, they can be approached by the clinician, the clinical support staff, like a nurse or medical assistant, or from the research team. This is on purpose because, again, this has to be feasible in a real orthopedic setting. We want to see what orthopedic teams are willing and comfortable and able to do. And then we want to see if that actually impacts how much whether patients enroll and then how much they engage with the intervention. So we'll be monitoring those things. We're defining chronic pain as pain for at least 3 months, and symptoms of depression or anxiety are going to be screened with PROMIS measures. Those are standard of care measures we get on everybody in our orthopedic clinics, and they have to have a score of 55 or higher. So of particular note, we're screening with PROMIS, but our actual outcome measures are PHQ ADS. For exclusion criteria, a couple that I just want to highlight, patients cannot have just had surgery or planning to have surgery during the study period. They cannot be in an active suicidal, homicidal ideation phase or any other psychiatric crisis, no prior psychiatric hospitalization in the last 6 months, and no psychiatric med change for the past 1 month. We want them to be relatively stable as far as we know at baseline in terms of their medications from that standpoint. And then at this point, we're planning to exclude patients who are currently using a mental health app or seeing a therapist in person, for a mental health standpoint, not a physical therapist. And then also we're excluding patients who don't have access to a smartphone.
Abby, can I ask what might be a dumb question? You're including these people with anxiety if they're 55 or above, but the standard deviation on those PROMIS is 10. So the people that you would be recruiting would be considered within the normal range based on the PROMIS. So can you have a justification for that? Because a reviewer might want to know that.
Yes, and we have gotten that feedback too. So in our pilot work, patients who are in that subclinical threshold improved just as much as patients who exceeded that threshold. We also have data that has not yet published, but I'm working on it, that compares patients' PROMIS scores in this orthopedic setting to a psychologist's DSM-5 diagnosis based on DSM-5 criteria. And the PROMIS depression score of 53 was actually the most sensitive and specific to predict a depressive disorder as a diagnosis. So we're trying to get that in there as well. But yes.
Great, super important to show that to the reviewers.
Thank you. So this is this schematic of our design. So for the initial 8 weeks, patients will be randomized to either the digital intervention, which is WISA for chronic pain, in addition to usual care, or usual care alone. And our primary outcome of this entire study is at 8 weeks with the PHQ ADS, looking at mean differences and improvement between those two groups. That's aim 1. And then for aim 2, we're going to take people at that 8-week mark and look at their response. So if their PHQ ADS score improves by at least 7 points, we're considering that a responder. And if they don't, then they're non-responders. That number of 7 points is a question I would love to come back to, but it's basically cited as the 2 SEM difference for like a conservative minimal clinically important difference. And again, this is not for our outcome measure. This is nothing to do with aim 1. This is just to re-randomize participants. And we want to err on the side of re-randomizing rather than not, because if you're not responding, we want to do something more for you. And then we're going to compare patients who either continued what they were already getting, so essentially a longer dose of the digital intervention or just usual care, and compare those patients to these green boxes where patients receive augmentation with a printed guide in addition to usual care. To give more background on the printed intervention, we developed this as part of our pilot work funded by the CPMH. It's a 4-page guide. It's a resource guide. So it is not in itself that self-help handout, but it describes local and national resources. Some are virtual, some are in person. A lot of them are free. Otherwise, they're low or reduced cost. And it's meant to be culturally sensitive and meet needs of a variety of socioeconomic and racial and demographic backgrounds. It is also meant to mirror the behavioral mechanisms that the digital intervention provides. So when patients saw this in our pilot work, we were planning to use it as our control enhanced usual care intervention. And they said, I love this. Some people said, I would prefer this. I really want to use it. I want to share it with people. So that's the printed guide that they'll get. And then again, aim 3 is that implementation related aim. So this will be a mixed methods approach. We're going to track patients, our reach, which is essentially, did patients actually enroll in this study or not? Are they willing to do anything related to mental health care in this orthopedic setting? Engagement will look at how much patients actually engage with the intervention they get. From the app standpoint, we will get a vast amount of metadata and we can tell how many interactions they have with the app. From the printed guide standpoint, it will have to be pretty much self-reported of how many times they're using this guide and seeking out those interventions. And then we also want to look at the one piece, again, a question for the end is whether patients' preference of what intervention they get necessarily predicts the effectiveness of the intervention. So if someone ends up randomized to this digital arm and they say, I'm not a digital person, I want the printed version, well, are they going to do worse than someone who says, yes, I want the app and I'm getting the app? My concern there is that if we ask patients, what do you want? And then they don't get it, is that going to bias their response? In the grant, I do describe that by the end of the study period, everybody will get access to every intervention. So the participants will know that as well. And we'll conduct interviews of patients, some from each of these groups to say, you know, how is mental health discussed? How did you perceive mental health discussed in the orthopedic setting? Did it work for you? Did you like it? What did you think of the interventions? What affected how much you used it and how helpful you thought it would be? And then for the providers, we're going to interview clinicians and clinical teams, those who had kind of the best response rate, the best reach, and those who had the lowest reach and the lowest recruitment rate to see how they perceived what they were doing and what were those key factors that might have made a difference. There goes my light again. So I will go through this quickly, but we can always come back if you have questions. Again, the wording of aim 1 is listed here. Our main hypothesis is that if you receive WISA plus usual care, you'll have greater mean improvement in depression and anxiety symptoms on PHQ ADS at 8 weeks. We also have a mediation analysis planned to look at 3 behavioral mechanisms: behavioral activation, pain acceptance, and sleep quality. The app also does address sleep. And we have some pilot data to support these mechanisms. So this will be an intent to treat and COVA approach, and we'll control for baseline PHQ ADS score, sex, race, and then our randomization will be stratified by age. We know that musculoskeletal causes of pain can be different from younger to older adults, whether it's irreversible versus reversible. And then also tech savviness is not perfectly correlated, but there is a correlation between age and comfort with technology. For AIM-2, our main hypothesis kind of mirrors AIM-1. So we're hypothesizing that augmentation with the printed resource guide, so these purple boxes, will have a greater mean improvement in depression and anxiety scores than people who continue their assigned intervention. If they didn't respond at 8 weeks, we don't expect them to respond at 16 weeks if we don't do something new. Our analysis also will be analogous to AIM-1. We will look at these pooled subsets. We'll also look at this purple versus this green, and then this purple versus this green, and a couple other smart adaptive intervention sequences in our secondary analyses. And then finally, for AIM-3, we have 2 hypotheses right now. This happened last week, so again, a place that I would love feedback. Initial hypothesis 3A is that initial discussion by the clinician rather than a support team member will increase the likelihood of patient enrollment in the trial. That's what we're calling REACH. And then also engagement with the trial mental health interventions. So we'll use regression analyses to look at these. And again, we're going to conduct semi-structured interviews with patients and providers. And then we'll also use a couple other implementation measures, which are short measures looking at acceptability of the intervention that either the clinician gave or the participant received, and the appropriateness and feasibility of these things in the orthopedic setting. And then this is the hypothesis I added less than a week ago, 3B. Patients whose intervention preference, whether that's digital or printed, if that matches their assigned intervention, they will have greater mean improvements in their depression and anxiety scores compared to patients whose preferred and assigned interventions are discordant, whether they specifically did not want what they got, essentially. And again, we hypothesize no mean difference. I think these purple circles are those groups that we can compare the discordant versus concordant preferences and see if there's a difference in their effectiveness. So our research team includes a variety of experts who I'm very indebted to. Joanna Abraham will be our implementation mixed methods expert. Ryan Calpe is an orthopedic surgeon who is also part of the Center for actually most people here are part of the Center for Perioperative Mental Health. Ryan is running the Orthopedic R34 RCT for the Center for Perioperative Mental Health. And so we'll have expertise in recruiting and retaining and running a mental health related trial in orthopedics. Charles Goss is my biostatistician who I'm indebted to and has smart expertise and interest. And then finally, Dr. Nickel, again, has given much feedback in addition to Katie Kenoy on all of the design and some of the mental health and digital health aspects of this trial. We're also proposing to have a study advisory board, including Professor Phil Miller, who has 50 years of experience with complex trial design. I have 2 patient representatives who have written support letters and will be giving us feedback throughout the study period. And then finally, we secured a third-party payer representative who's the medical director for virtual care for Cigna to give us that the third-party payer perspective, because again, if this is effective, we want it to actually become implemented in standard care. And we think insurance is a big part of that. So this is my last key slide. And these are my questions for you. I will take any and all feedback, but a couple of key points based on revisions we've made from prior feedback. So in general, AIM-2 and the whole smart design, do you find it compelling, understandable? Do the analyses seem to make sense? And again, specifically related to that re-randomization based on the responder cutoff of 7 points for PHQ ADS, do you agree with that number and justification? And then specifically from a mental health standpoint, I've gotten mixed feedback on the suicide and safety protocol that we should implement. The way it's currently written, whenever patients answer the suicide question, the last question of the PHQ-9 measure, if they indicate any level of suicidality, as soon as they finish this measure, everything is going to be collected virtually. We will never necessarily see a patient after they're enrolled. So they will be directly filtered to a screen that shows suicide resources, crisis protocols, but we may not necessarily contact them by phone. Again, we aren't going to see them as part of clinical care or the research trial in a scheduled fashion. So is that sufficient, or do we need an in-person follow-up, and what would that look like? The other piece that I have questions about is AIM-3. So for DNI folks, does this sound DNI enough to you? Are there any opportunities we're missing from that standpoint? And what do you think about asking patients what their preference is in terms of interventions? Will that bias things too much? And lastly, I was looking for a tech savvy measure to consider as a covariate to measure. I found a Pew digital savviness score from the Pew Research Center. It does not look formally validated, but if anybody knows of anything, I would be happy to hear it. And one kind of administrative question, is this a phase 2 or phase 3 clinical trial? And does it matter from an administrative standpoint or from a grant writing standpoint? Hopefully that's a quick question, but I would love your input on that. So that's it. I want to thank everybody who has given me feedback, who has funded me, including especially the mHealth Research Corps and the Center for Perioperative Mental Health. That's all I've got, and I'm happy to hear your feedback for the rest of the time.
Okay, thanks, Abby, so much for that great overview and for really succinctly outlining your questions. So I think for the rest of the time, what we'll do, people can put questions in the chat if you like. You can also blurt them out. But what I wanted to do was, I don't know, Abby, if you could, yeah, there we go. So does anybody have any responses to the first question about AIM-2 or any questions that are not listed on this slide, first of all? So Eric Lenz, please go for it. And I think, we cannot hear you.
Yeah, we can't hear you.
Oops. I don't know if there's something I can do to fix that.
I think he might be frozen now.
Yep, he might be
Okay.
coming to my office. Come in.
Mm,
Here he is.
there you go.
Go for it.
That's one good thing about being next to Ginger, one of the many good things. So here's my thought. I think overall, this is really great to see, Abby. But the one thought about the smart design, I just sense that this is the kind of thing that reviewers are going to peck at a lot. And you want the smart design to be added value, not subtracted value for a grant. And I guess one thing I was wondering is whether giving someone something printed, some printed materials, that sounds to me like a de-intensification, more than an intensification of services. Like, I guess in my mind, one would offer a digital intervention first because it's cheaper than human beings. And then if that didn't work out, then the question in my mind is, well, maybe they just didn't engage very well with the digit. They weren't tech savvy enough. What if you then gave the same intervention from a human being, which would be an intensification of service?
So we had that initially, and I think I can logistically do it. However, the reason we took that out is because right now it doesn't, from our pilot work and from everything I know just clinically, that would not be feasible in the orthopedic setting. And so our concern is, okay, we can show this is effective, but in the foreseeable future, that's not going to happen. Which is, and based on the feedback I got from the CPMH pilot work, there was, we should do something with this information that patients are saying, hey, I would like a printed resource. And you're right. So the other line I'm trying to walk is that in the mental health world and in a lot of worlds, printed guides, like a handout does nothing. It's not considered an intervention. That I have found some meta-analyses showing there can be a small effect, which is great. I mean, small is better than nothing. And having anything related to mental health in the orthopedic world is different than what they currently get. And so I don't think it's going to be as good as a digital intervention on the large scale. Now, for certain patients, it might be, but I agree. This is that's that tension that I'm trying to say, like, look, I think this is helpful, but I'm not by any means hinging this whole R01 on just a printed guide. I don't know if you have other ideas to respond to that, though.
Well, those are good counter arguments, I would say, and if they're made explicit in the grant, then that may be okay. I suppose that one could say, you say it's not feasible, well, why is it not feasible? Especially if it were, if, let's say, if 80% of the people benefited from the digital intervention, so you only needed the other 20% to get a human intervention, would that be feasible? If you think it's not, and there's, it's just not feasible, then you can make that argument, but.
This would be a question for you. So, the way we've done it, the way we did our pilot, we actually compared the WISA users to usual care plus a in-person psychological counseling. And we had Barry Hong, who is our psychologist in the Living Well Center, which is an orthopedic center, but addresses mental health. That's not standard care pretty much anywhere else in the country. And one of the challenges, even in that setting, is access. So in a research setting, yes, we can do that, but on a large scale, nobody else has that infrastructure. And even if you say, okay, in the orthopedic world, you do need, a psychologist, a counselor, a therapist, anybody, there's still a 3-month wait time. So that was the feedback we kept getting from patients and providers. Some of the patients said, I know I need it, I can't get it, which is why we didn't.
Right.
Yeah.
Well,
Yeah.
over to other people who probably have questions and
Yeah.
good comments too, but thank you.
I think that was a good description of your rationale there, but yeah, I think it's hard to, balance between like what makes the most sense and what you think would work the best versus what actually could be, moved out
Yeah.
into real practice. So, okay. And I know there might have been others that had questions or thoughts about AIM2. Ellen, did you have anything that you wanted to talk about?
Yeah, no, thanks for this discussion and for a great presentation, Abby. This was really great. I did have the, similar reaction to some of what Eric described. And I also wondered another way you could kind of flip the AIM. You did mention that the printed guide at one point was your control condition. And I did wonder a bit about, either a 3-arm trial or 2-arm. I mean, you do know all these folks have depression. So I almost wonder what's the rationale for not even referring, kind of keeping some of them in usual care. One might expect you to at least provide them a referral, which is, it seems like what the printed guide is offering. And so, one way you could flip the aims is also to focus on, again, some version of like comparing, digital versus printed guide and looking at uptake of care. Like you said, there's this issue that most people can't get access to mental health care, which I completely agree. And, your printed guide is going to give them lots of ideas, but we know that the reality is most of them wouldn't be able to get access to it. But I know what we've found in our work, doing similar comparisons with, digital versus referral to usual care for eating disorders, 80% plus of people will at least start the digital versus, something like 20% in your referral condition ever get treatment. So that, might be, I'd like to see, I think if I were reviewing it, some focus on like this uptake question, because I think that's really critical. And that's where your digital often really adds value. So that's just, one potential thought for you about that.
Got it. So again, this is really helping me from a mental health standpoint to see what mental health reviewers will say. We had a 3-arm trial. It was digital, printed, and then usual care. And it was 100 participants per group. And then we have 9 like post-second phase randomization groups. And so it made that part messier. And so we actually came back and we were trying to think, and what do you re-randomize to? If you start with the digital and we say, okay, if that's a de-escalation, but if you are printed and then you get digital, is that an escalation? And then what? So it got really messy. And then when I kind of focused in on like, what is my question? The big question is digital. We think that will be most effective and actually accessible possible. But again, I don't want to neglect the printed guide. And then from this feedback we got from especially clinicians, but also patients, like, if it's not effective, even if it's a piece of paper, orthopedic surgeons will not give out a piece of paper on depression and anxiety if they don't know it's effective. They said, if I know this will help my outcomes, I will do it. I'm busy, but I will do it. But if I'm just, doing something else in addition to what I already do, I won't do it unless I know it's going to work. So I tried to make that argument, but it sounds like I really need to make that argument in the grant text. But that's why we took out that the extra printed guide 3-arm initially. I don't know if that would convince you as a reviewer, though.
It looks like Catherine has some more thoughts.
Yeah.
Again, as somebody really interested in the issue of uptake and reach, I think that's what I always kind of go back to, because I think that's, again, what your digital really adds value.
And I'd love your thoughts on, like, if looking at engagement with the interventions, if that starts to get to your question, like the AIM-3 stuff, does that start to get your questions about uptake? I don't know.
I think, Abby, you're in a really hard spot because you're coming at an orthopedic condition and you're doing a mental health intervention. And so I guess the question I would ask you is, what study section are you planning to go to? And who do you think your reviewers are going to be? Because I have a list of questions related to the orthopedic part, and someone like myself could actually easily end up on your review panel. In the same way that someone like Ginger or Ellen could end up on your review panel, coming at it a very different perspective. So I share Ellen and Eric's concern about AIM-2. Like, to me, like an AIM that's giving out a printed material for a non-responder is like totally uninteresting and will get you into the non-discussed category. But that would be my bias. And I don't know anything about mental health. The one couple things I was thinking about is you're a new investigator, right?
Mm-hmm.
If you haven't talked to her already, I know you connected a little bit with Linda Van Dillen.
Mm-hmm.
Yeah, so think about adding her to your scientific advisory committee, because she will give you street cred for running a clinical trial in low back pain.
Okay, that's a good.
And I think that would be great. A design that she used for her trial is not unlike what you did, except she did a booster treatments for physical therapy versus responder, non-responder for mental health.
Okay.
But talking with her might give you some ideas about how to restructure that. Another thing I have, and this comes from a bias of being on an international group, worried about trials that use usual care as the control. So usual care is a mess, right? So what usual care is in St. Louis is not what usual care is in Chesterfield, and it's not maybe what usual care is in Washington, D.C. and around the world. And so if you could make sure that you include specific information that you are going to map and define what usual care is and record it for your participants, I think that will be incredibly important, because some of these variables could change because their pain is changing unrelated to their mental health. And so some sort of analysis might actually be an interesting substitute or in conjunction with AIM-2 related to what their usual care is.
Got it. That's a great point. I specifically state what we're considering usual care, but making an analysis related to that is really helpful. And then just in case this guides other questions. So this is going to NIMH. The program officer said they have a specific study section for this mechanism. So I think from what she said, this should be like mental health researchers who are very familiar with DNI and to some degree, maybe adaptive trials, but they will probably bring in a back pain or a pain expert. And so I'm trying to write, I mean, I could write a lot more about chronic back pain, but I'm trying to keep it mental health related without saying anything that's going to raise flags from a back pain perspective. But again, that I am not sure I'm doing the balance correctly.
Well, I wonder if it's a clinical trial, so you're going to get a space to put a protocol in, or no?
So we have a place, so we can have the study analysis, like the statistical analysis plan and flesh out, we have extra pages for that part, yeah.
That's what I'm wondering, is maybe you can stick some of the low back, save your pages in the 12 pages and stuff some of this low back pain stuff in more in depth into the unlimited pages, so that you can appease both individuals.
Got it.
That's great advice. I just can say, from both perspectives, like as you look at that part of an application, a lot of times it's just repeat of what's already, you've already seen. So that makes sense to add that detail, because I agree. I think it's important. And it only takes one person to bring that question. If it's the one person that has that expertise on the committee, it can be really important. So that's really great advice.
Yeah. Can I add one related follow-up to that? And I don't know if this is what you're getting at, Catherine. But I suppose I maybe expected to see in the aims, like I think your rationale is, and again, correct me if I'm wrong, I'm not an expert in low back pain, but you know, if you better decrease anxiety and depression, you'll have better outcomes for back pain. So I think I was also looking for that sort of like mediational analysis, which would also really fit with, you did a nice job mapping out what's the target of the, which as you've probably read in the RFA, you know, NIMH loves targets. So that'll need to be a big part of, you know, responding to that RFA. But I think you could also argue that if again, I'm correct, you know, depression and anxiety are a really important target for ultimately improving back pain. So you would want to see, you know, in your digital versus usual care condition, for example, that, you know, that mediation is really occurring, you know, and you're better, again, like targeting depression and anxiety as a mechanism to target pain. So I think that's, you know, just something else that I maybe expected to see. So I don't know if that's exactly what you were trying to say, Catherine, but oh, okay. But I just wanted to like clarify, you know, from my perspective, from the mental health angle, what I would have been, you know, maybe looking for.
Got it. Do you think, so, and that's interesting too, because I'm trying to focus on like mental health outcomes because it's going to NIMH. Would that be appropriate as a secondary analysis, like, and keep the primary analysis like mental health focus, but then
Yeah, I was going to say the same thing. I mean, I was really looking for like, how are you characterizing this in terms of your analysis plan? How are you going to show that this is your mechanism? Because it, you know, kind of reads like that's what the mechanism is, and you really want to highlight that. I think that makes sense as a secondary, you know, goal, or, and, you know, even an exploratory analysis. But I think for your study, it makes sense. It could probably be secondary. What do others think?
it's a nice.
I think so, but it still seems like a really, like, that's the health outcome. You know, I guess it's like, this isn't just a general old population that you found some other way with depression and anxiety. You know, they're presenting for surgery or to this clinic. So I don't know, you know, I mean, even in that study section, I think they're pretty interested in like the health outcomes, and again, very interested in mechanistic work. So, I mean, I think that could be like, again, I don't remember exactly how your aims were structured, but you could envision that as a really important aim too, you know, that you're looking at. And that really fits with, again, what that RFA would talk about targets, you know, so you're really going to look at, you know, reduction in depression and anxiety as a mediator for changes in pain. And, you know, you would expect that, you know, is a much more like robust relation in your intervention versus your control condition. So.
And I would rather see that than the current aim 2 where you give them an extra piece of paper. I would rather that you up your N to
Right.
make sure that you can do a very careful mediator analysis with sufficient power to detect things that you think will be important.
So I'm taking a step back, and I don't know what I can do in a month and a half, but if it were up to you, would you just take out the printed guide? Like completely from the.
I would just add the print. I mean, again, you said orthopedic surgeons won't give it, but to me, that's like a low hanging fruit, no brainer that the mental health people are going to be like, why wouldn't you give them the paper
Right.
version?
You've already identified them as
Yeah.
having a problem. So it's sort of like usual care plus printed guide, usual care plus digital. To me, that would be quite compelling.
The other issue is, I mean, this is the NIH, it's not PCORI. And so you run into this challenge of you're testing against usual care, but we all know that usual care isn't perfect. And so sometimes you end up with reviewers who want you to test against best care, not usual care, because what they want to know is it really worth doing this more than we know we already have good things? You know, implementation becomes the other question. And so that's another, again, depending on the reviewer that you get, that's going to be another issue as well.
And that goes back to the in-person piece to it, which we had, but then for the reasons that I explained, we took out. Okay, good to know.
I think that's a great question. Just knowing that mechanism and the people probably on your study section, it is all about effectiveness. And I think pretty focused on like what's available in the real world. So I think I'd argue that I'm okay with, again, like the compare, you know, you don't need to compare it necessarily to best care. I don't think that that's exactly what this mechanism is looking for. I think again, then the argument just becomes clear, like we can either refer patients via a printed guide, or we can give them something that they can download and access today. And you can look at things like, again, how many people actually get any mental health care versus the, via those two mechanisms, as well as whether outcomes are improved in the digital. Because chances are you're going to find in the printed guide, again, probably like 20% or less of people will ever get hooked up with any kind of meaningful care, even though they may like your printed guide theoretically. I'm sure it's really wonderful, but they'll run into all those like barrier issues that you discuss, like, sorry, I'm not taking patients, they don't take my insurance, except, the list of stuff.
Yeah. Okay. I'm doing long and hard and figure this out. So to take a step back and to play devil's advocate, so say like, if these big picture things are not changed, can I get feedback too on like the suicide safety protocol and like the responder cutoff of like PHQ ADS, just from a logistical standpoint?
So are you asking, you want feedback on those things?
Yes, I get so, and I will say, so I know like from the MHealth Research Corps, I heard like, I don't need an in-person follow-up or a phone follow-up, which would be great. And that's how I have it written. I just finished an ICTS Research Forum mock review a couple of weeks ago. And one person said, you know what, in our trial, we had a person to follow up with any crises. So I don't, and again, you guys are the mental health experts, so I will defer to you, but that's just the piece that I'm like trying to, again, walk the line.
Yep. Well, I mean, I think, we've talked about this a little bit, and there are different ways that you can do this. Like there are products out there on the market that don't involve an in-person evaluation if somebody is, detected as having suicidality, for example. And so, I think that for this study, there just has to be a mechanism in place where we help people get to the right service. But you could probably think about having like a digital assessment, right? Because the American Foundation for Suicide Prevention, for example, they've got a tool, and that tool assesses and then allows a channel of communication back and forth between a clinician and a person who is reporting that they're feeling suicidal, but there's never any identifying information exchanged. It's basically, okay, what's going on? Okay, here's a resource. And that's, so basically navigating to a resource. So there's that model. Then there's the model of, okay, you're under our care. This is part of the care. So we provide the care. And I think both could potentially make sense, but, one involves much more of a protocol and paying a person versus, having a digital way of following up and having a person available to do that.
And the other thing I worry about is, again, we're not going to see these patients as part of the trial or clinic. So if we reach out and then we don't respond, or they don't respond, then what do we do? And what's our responsibility?
Exactly.
Yep.
Right. You can't like walk them to the ER. Again, I guess I would argue with this mechanism, it's all about effectiveness. It's about real, efficacy or effectiveness, I should say, of real world intervention. So I think I would probably, and I've done similar things in grants in response to this mechanism, argue for something super scalable. Again, if somebody endorses, that item, we've done things like, send them to the National Suicide Lifeline, or now you even have 988 available. I mean, there's nothing, I don't know that can do. That's as good as we would be able to do. I mean, again, these people are located, if they're located all over the country or whatever, there's really nothing more than you can do in that moment anyway. So, I mean, I think you have a strong argument for something like that.
Okay.
And actually, Abby, you could, our 988 regional hub is actually quite robust, and they're pretty far along. They offer mobile outreach services and things like that. And so that sort of depends a little bit on where you live, how far along they are in planning their services. But that could be something that, we actually make as part of our MHRC, like this is some, text and how you could incorporate this into your grant. But it's a great resource. And basically what we would do is just say, that's the place to call, and you can, program your digital tool actually to directly connect people there when when they score a certain score on their assessment.
Okay, that's really helpful. And then also you're mentioning efficacy versus effectiveness, like phase 2 versus 3. Does it really matter? And if so, which should this be?
Yeah, I mean, I'd probably write phase 3 because again, it's all about effectiveness. So you're really trying to argue for, again, something very, real world, broad scale testing of something that you think already has reasonable efficacy. I mean, that's, I think, the whole point of the mechanism. So I think phase 3, although I don't know that anybody probably pays that much attention to that one little spot where you mark
It
that.
doesn't affect like administrative requirements or like you have to do.
That's a good. Ginger may know better than me. I really don't know, actually.
I mean, so one of the reasons that they want to know is, for safety planning purposes, right? So phase 3 clinical trial is a fully powered study where you've basically got, effectiveness you've established minimally safety. And so now you're doing a fully powered randomized study. So you're absolutely doing aim 3, but it's basically, the difference between effectiveness and efficacy, safety and tolerability, you're just proving that with a fully powered study.
Okay. That's helpful.
Okay, so I think we are down to the last few minutes. Any final questions? We probably can take maybe one more or comments.
And if anyone has a tech savvy measure, I would love to know. I can't find one.
Well, I've got a couple that we use for schizophrenia patients, but I'm sure those are not going to be exactly applicable, but I'm glad to send those to you.
Okay, thanks.
Anybody have any others they want to donate to the cause? No, but it's actually a good point. This is one of those things that people will start asking for, I think, and reviewers will be interested in. So, if anybody comes across anything, we will definitely share it back with the group. So, all right. So it sounds like no additional questions or comments. Abby, did you have anything else in the last minute or two?
That is it. I appreciate all of your feedback and your time and expertise as always.
Okay. Well, thanks everybody for joining and for the very helpful feedback. And we will be, as I said, sending you all a survey to get your feedback on this and some of the other things that we are planning to do and needs. I think that's it for now. Katie or Stephanie or Teddy, is there anything else that we need to announce?
No, great presentation. Thank you. Great discussion. So we really appreciate it.
Yep. All right. Well, that's a great way to wrap up a Monday morning. Thanks, everybody. Hope you have a good rest of the week and stay tuned for more information.
Thank you.
Bye.
Bye.
Thanks so much. Bye.